Medicine Committee of Asia Oceania Federation of Obstetrics and Gynecology. He has been a peer reviewer for many journal of OBGY in India. He's currently the professor and head of department of OBG at Gandhinath H Medical College, and has many publications, national and international, on credit and part of the research team. So I would like to invite Dr. Professor Milind Shah to please uh, introduce the today's topic.
Thank you very much, Dr. Divya Srimal. It's really a kind introduction. But friends, I always felt that whenever we speak about the birth defects, the drugs, they always rank one as far as the cause is concerned, because there are so many drugs we use in our obstetric practice. And that's why this idea came to my mind to have this particular webinar series where we'll discuss all these drugs. And as Purnima was saying, it's the brainchild of Milinsha. Very true. But I just, just like a Devki, the entire nurturing is done by Purnima. So, Purnima, I appreciate that you are like Yashoda to this webinar series. As I was occupied with that Australian, Singapore visits and so many other things were happening. But I wanted to convey to all our Ispatians, all OBGYNs rather in our country, should understand about the all details of pharmacokinetics of all these drugs which we use purposefully, sometimes inadvertently, and rather when the cases are posed in front of us saying that they have taken that particular drug, doctor, please answer me how it is going to matter actually as far as my pregnancy is concerned, my baby is concerned. And that's how we got a wonderful actually the co-conveners for this webinar series, Dr. Purnima, Dr. Priya, and Dr. Ruchika. In fact, we wanted to cover the entire zones, all four zones of country, and that's why I told all the people, prominent people from the various zones of the country to be actually with us to spread this particular message, and that's how we have Dr. Jyoti actually from Gwalior, Dr. Sheila Mane from Bengaluru, and then Dr. Apurva from the east part of the country, and of course Priya who is covering the all western zone per se. Then I was thinking the person who is doing wonderful work in this field as far as the birth defects are concerned is none other than a very close friend of mine, Dr. Ashok Khurana. So I asked, and I'm so thankful to you, Ashok. I know that you are a busy schedule. I have seen it, and so many patients who visit your center always tell about it. The another two guests of honor, the Dr. Saurabh Dani and Dr. Ameya Purandare. Saurabh is my predecessor and he has done a wonderful work for this path. So I thought he's the best one actually to come and join. Purnima, Saurabh has joined today or he's yet to join. We'll have to just check. Yeah. And the Ameya is now AMOX president. So whatever is happening in our state of Maharashtra, he's become like a king. He's coming. Yeah. Saurabh has come. Na? Good Saurabh. Yeah. Yes, yes. Then we thought of the good chairpersons who can manage all these actually the lecture series, which is again unique of its own kind. And then we got Dr. Geeta and Dr. Madhuri Joshi, who will be here to chair these sessions. And we got a very wonderful speaker to speak about all these pharmacokinetics of the progestins, because it is one of the drug which is actually used very abundantly, starting from allolestatol in 1980s till the dydrogesterone, which has come very openly available in the market to date. And that's why utilization of all those things definitely needs a science behind it, which we are going to discuss with the help of all these wonderful speakers, Dr. Ragini, as well as another good friend, Dr. Danny, as well. We often meet in conferences, but Danny, we are really looking forward. I know that the questions always come to our mind whenever it comes to the any particular topic in the medicine, and that's why the panel discussion is must. And then we have a Priya and Ruchika to moderate this wonderful panel on progestins use and abuse that we can very well cover. And we have a wonderful galaxy of the panelists. I'm not going to take the all names because that itself will consume a lot of time, but we can definitely make a major difference after discussion to get a good knowledge about things. And finally, I cannot forget the Corona. The Karthik was so much, available with us to do all these tasks, and that's why this child is coming in front of you. And I'm very sure It is going to create a lot of happiness to you as far as the academic feast is concerned, and it's going to bring you more insight about the pharmacokinetics of drugs. So thank you very much for joining you all and taking initiatives to implementing this particular webinar series. Yes, thank you, Purnima.
Divya?
Yeah.
I don't know if she's
Divya,
having a bit of a problem.
yeah.
Maybe that
So let me tell the co-conveners to speak themselves because I understand she must be busy with something. But
no,
Purnima, you can
I think
start.
I'll introduce Dr. Ashok Khurana first because
Yeah.
he was
Yeah.
the early bird. He was the first one to come actually.
Yes. Yes. Yes.
So I don't know if she can show the slide, but otherwise, I don't think he needs any introduction. He is very well renowned and one of the foremost fetal medicine experts in India. And he had a very brilliant career because he had his undergraduate and postgraduate training from All India Institute of Medical Sciences. And then he's also done a specialization in fetal medicine from a foreign university, that is Herlev Hospital in Denmark, in ultrasound. He has really brought up the SFM during his presidency into a very, very vibrant organization. And whenever there are webinars of SFM, all of us mark it on our calendar and we make sure that we attend because we learn so much from these webinars. Besides that, he has his own center. He's the chairman and consultant at the ultrasound lab in New Delhi and Professor School of Health Sciences, Dubrovnik International University of Croatia, past president of SFM, as I said, former ISWOG, Indian International Society of Ultrasound and Obstetrics and Gynecology ambassador in India. ISWOG is also doing excellent work in this field, and we always follow their guidelines. Former Dean, Indian College of Medical Ultrasound, and President-elect Indian Federation of Ultrasound in Medicine and Biology. So thank you, sir, for being here, and we really welcome you, and we are eager to listen to your few words from you.
Thank you. Thank you so much for inviting me here. Thank you, Milind, for including me on this introductory webinar. And thank you, Dr. Purnima, for this absolutely very kind introduction. We know for sure that the care of the fetus and the care of the pregnancy today is no longer done by an individual. We used to call it multidisciplinary, which means a lot of us as specialists would get together and come to a conclusion. But we do understand that in the Indian system of health delivery today, we have to change. We cannot any longer expect that 5 or 7 of us can get together at the same time. We cannot expect that the patient will be able to meet 7 people individually. But what we have to do is to evolve into what is now called interdisciplinary, which means that each one of us, in spite of our primary specialization, has to have a wide knowledge to make sure that we are able to deliver the best to our pregnancies and have the best outcome for the mother and the best outcome for the fetus. And therefore, I was not surprised at all when, even though the topic is progesterone, that I am actually the chief guest at this session, because the amount we can learn about things is so different today when you are at a webinar compared to when you are trying to analyze it, whether it's ChatGPT or Google or wherever. There is a lot to be learned. And I'm looking forward to learn all about what I used to use for every single patient who didn't seem to be doing well in pregnancy, which was our good old Prolyton depot and an oil deposit, which was used universally. And then we realized it's doing more harm than good. And it took us a long many years. It took us 4 decades to understand that. What we're able to not understand today is that progesterone is very useful for a lot of things, but everybody seems to be on oral, vaginal, and injectable at the same time. And I do hope we're going to find answers to that. We know that new drugs come out all the time, some of which have been adequately evaluated and some of which have been accelerated, and that the role of the pharmaceutical industry now is not always above board, and you and me need this education. So I'm absolutely fascinated that, yes, indeed, we're able to do this. And also that niggling doubt you always have at the back of your mind that if this patient was on a progesterone at the beginning of pregnancy, and depending on the sex of the fetus, is something going to go wrong, or is anything going to go wrong? All these answers are things we need to understand. So thank you so much for putting this together. And I truly hope that I'm not just the chief guest, but the chief learner in today's webinar. Thank you indeed.
So nice of you, Ashok. So humble. Thank you.
Dr. Purnima, you have to unmute yourself.
Yeah.
So, I would like to introduce the co-conveners of this meeting. First of all, Dr. Purnima Satoskar. She doesn't need any introduction. She is the consultant at Jaslok Hospital and Research Center, former professor and head of unit at St. Medical College and Narosji Wadia. She introduced the MUHS fellowship at Narosji Wadia quite a few years back. She is the current chair for AICC RCOG West Zone, secretary for Indian Society of Prenatal Diagnosis and Therapy. She is a recipient of Hargobind Khurana Fellowship in Fetal Medicine at Beth Israel Deaconess Medical Center, Harvard, Boston in 2000. And she has published over 40 papers in national and international journal. So I welcome you, ma'am.
Thank you.
Dr. Priya Vora. She is MOG's Managing Council member since 11 years, Youth Council mentor since 8 years, current president of Mumbai Menopause Society, vice president at AMWI Mumbai branch. She has contributed in various journals and books, editor of the books Drugs and in Obs and Gynecology, which is the theme of our webinar this season. And she's also the editor of the book Menopause Update, Evangel Publishers 2025. I welcome you, Dr. Priya. And Dr. Ruchika Garg. She is the professor at Department of Obs and Gynae at SN Medical College, Agra. She is currently the editor-in-chief, a Journal of Midlife Health, executive editor, Journal of Suffolk, South Asia Federation of Obstetrics and Gynecology. She has been an editor in the 19th edition of Shaw's textbook and gynecology, and editor of multiple books in Obs and Gynae, MCQs, drugs and gynae, medical disorders in pregnancy. I would like to welcome Dr. Ruchika Garg as well. Now, I will request Dr. Purnima to welcome our chief guest of honor.
So I have great pleasure in welcoming Dr. Saurabh and Dr. Ameya Purandare, who are the guests of honor. Saurabh is a consultant in OBGYN at GEM, Namaha, Cloud9 and HCG in Mumbai, and he's the former president of ISPAT. He has a special interest in high-risk pregnancy and newborn screening. And during his presidency of ISPAT, he was very well known for going all over India and spreading the message of newborn screening, which was a very important message. Welcome, Saurabh. And Dr. Ameya Purandare has been our student at Wadia Maternity Hospital, and I've worked closely with him. And he is now the president of the Association of Maharashtra OBGYN Societies. He's recently been installed, and I'm sure he's going to do a very fine job because he is an academician. He has, of course, taken part in a lot of academic activities during Mumbai Obstetric Gynec Society programs, and he has also got publications and authored several chapters. Welcome, Ameya.
Thank you, madam.
Yes. Yeah.
Priya?
I think the lecture is there first, right?
Yeah, but yeah,
Share.
Saurabh and Amey want to say something.
Yeah, sure.
Yeah, please.
So, respected IPAS President Dr. Milind Shah, chief guest for today's webinar, the legendary Dr. Ashok Khurana, the conveners, my teacher, Dr. Purnima Satoskar, my colleagues, Dr. Priya Vora and Dr. Ruchika Garg. It is indeed a privilege to be here today as the guest of honor for this academic gathering focused on a hormone that is often understated yet profoundly influential, that is progesterone. In the symphony of reproductive health, progesterone plays the role of a silent stabilizer. While estrogen often takes the center stage and all the limelight, it is progesterone that brings balance, maturity, and sustainability. From regulating the menstrual cycle to supporting implantation and most importantly, promoting and maintaining pregnancy, its role is both fundamental and indispensable to reproductive endocrinology. However, in today's clinical practice, our understanding of progesterone has evolved significantly. In the earlier days, we just called it the luteal phase hormone, but now it has emerged as a key therapeutic agent across a spectrum of conditions like luteal phase defects, threatened miscarriage, repeated pregnancy loss, preterm birth, abnormal uterine bleeding, and also as a protective factor in hormone replacement therapies. What makes this CME especially relevant is its growing body of evidence guiding us towards more individualized and, more importantly, evidence based use of progesterone. The choice of the molecule, the route of administration, the dosage duration all require thoughtful clinical judgment and requires tailoring depending upon each patient and her symptoms. As clinicians, we are constantly navigating between tradition and transformation. Progesterone, in many ways, exemplifies this journey from conventional use to cutting edge applications backed by robust research. I commend the organizers led by Dr. Purnima Satoskar for bringing together eminent experts in the field of pharmacology, obstetrics, gynecology for this important topic. My heartiest acknowledgement and congratulations to Dr. Milind Shah for bringing this very relevant and practical webinar series for the benefit of our members. Because I'm sure that deliberations like this will enhance our knowledge and also translate into better, safer, and more effective patient care. So, friends, welcome once again. Enjoy. Let us learn together and let us use this platform of webinars not just to learn, but to question, to reflect, and more importantly, ultimately refine our practice. Thank you once again. And I wish this spectacular CME a grand success. Thank you.
Thank you.
Saurabh, few words
Yeah.
from you.
As ISPAT, we have always thought about birth defects, but I think we would have never come out with this idea because we are always focused on how to prevent birth defects, how to take care, manage, and looking at all the investigative side of it. But the first and the most important part, that is the medicines which are given to a pregnant woman, has often been overlooked. I think this is the first time ISPAT is taking up the series where any molecule which is given to a pregnant woman, which should be considered as a potential to cause a birth defect. And I think kudos to Milin and Dr. Purnima for even thinking about such a program. And I hope we cover most of the molecules that we commonly prescribe in antenatal care. And we dissect whether each of them are liable to cause any birth defects that we see in current practice. All the best.
Thank you. Friends, actually, Saurabh joined slightly late, but he had done wonderful work in the last year. And that's how actually it's a challenge for us as well now to carry forward this. Thank you very much, Saurabh, for your kind words. Yeah.
I will now request Dr. Satoskar to please introduce our chairperson for the talk.
Yeah, Divya have joined, Dr. Priya.
Yes.
Acha, okay, ma'am. Then please.
Yeah. So
Yeah,
I can
welcome, Priya.
introduce. Yeah.
Yes, yes.
So I would like to introduce our chairpersons. We have two chairpersons, Dr. Geeta Balsarkar. Madam is a professor, unit head at Wadia. She's an editor emeritus, Journal of Obstetrics and Gynec of India, vice president of MOGS. She's editor in chief, International Journal of Infertility and Fetal Medicine. President, she has been a president of the AMWI Mumbai branch and a president of Mumbai Menopause Society in the past. And also, I would like to welcome Dr. Madhuri Joshi. She is a consultant at Nanavati Max Super Speciality Hospital. She's a peer reviewer of Jogi, executive member of managing committee of the Mumbai Menopause Society, and she's even a CIMP. She trains the students for the IMS exam, the CIMP exam. Welcome, Dr. Madhuri. Over to you all both to conduct the talk session.
I hope Dr. Geeta madam will introduce the speaker. Has she
Uh,
joined?
yeah, thank you very much for this invitation, Dr. Milind and Dr. Purnima Satoskar. It's my pleasure to introduce Dr. Rajni Rokde, who has done MD in pharmacology. She's presently faculty at Pharmac at NGM Medical College, Nerul, founder director of Pharma Souls, and she is a former lecturer at St. GS Medical College, Mumbai, and Yenapoya Medical College, Mangalore. Worked with pharma majors like Abbott, Sanofi, Johnson and Johnson in various roles like medical advisor, head of pharmacovigilance and head medical information. Worked as CRO as associate director medical affairs and clinical research. He invited as a guest speaker and panelist in various forums including National Pharmacovigilance Conference, Pharma Tech Clinical Research Curriculum, etc. I'm sure we are all very eagerly waiting to have hear her deliberations on this particular topic. So over to you, Dr. Rajni Rokde.
Thank you, ma'am. Thank you for the nice introduction. And good evening, everyone. I hope I'm audible.
Yes.
Yes, ma'am.
I'll just share my slides. So at the outset, I would really like to thank Dr. Satoskar, my teacher from MBBS. So, and also ISPAT as an organization and everyone present here for giving me this opportunity. I will just share my slides.
We can see your slide, yeah.
Yeah, thank you for confirming that. Right. So thank you very much again for giving me this opportunity. And I'm indeed glad that, such kind of, what to say, a coexistence kind of, between the clinical and the paraclinical domains. So as to, in the interest of the patient safety and, knowing various aspects on pharmacology. So thank you so much. Yeah. To begin with, I'll just, take you like the basic terms that we know, like progestogen, or it's also called as progestagen, gestogen. I'm sure everybody knows this. So just to differentiate, this progestogen could be it's a molecule, either natural or synthetic, and shows similar effects as progesterone. It's a molecule which binds to the progesterone receptor and acts as an agonist. So all the natural as well as synthetic together, they fall under progestogen. Whereas the synthetic progesterones, which mimic the biological action of endogenous progesterone, these are called as progestins. As the name suggests, progestin, pro, means it favors the gestation or favors pregnancy, and hence the name. So these are substances which basically convert the estrogen primed proliferative endometrium and to make it more secretory and maintain pregnancy. If we see the evolution of progestins, it started way back actually in 1500, wherein actually only the ovarian corpus luteum was described. Then on, by 1929, progestins were discovered. And in around 1939, Adolf Buchanan, he actually received the Nobel Prize for Chemistry for investigating or discovering the progestin structure. The structure of progestin, that is the delta 4,3 ketosteroid. So that was discovered, and from there on, other progestins were discovered, and the newer and newer progestins were checked. Actually, after 1950, if you see, more of the other progestins were discovered. Yeah. As I'm sure everyone knows that progesterone is the precursor molecule for progesterone is cholesterol. And this is derived from cholesterol. The in-between step is pregnenolone, and then progesterone is formed. And that is how the endogenous progesterone is secreted. So if you see the structure of progestin, it's basically a 21 carbon steroid derived from cholesterol, and it is secreted by the corpus luteum, right? So almost around 10 to 20 milligrams per day is secreted by the corpus luteum. And this happens generally in the later half of menstrual cycle under the influence of LH. I'm sure all are here gynecologists, so I need not go through the menstrual cycle details and how progesterone is secreted. We will rather focus more on the pharmacology part. Placenta also starts secreting progesterone as well as estrogen from the second trimester till term. Coming to the synthetic progestins. So these are the drugs, like they have progesterone-like activity and they have high oral activity. Natural progesterone cannot be given orally as such. We have, of course, the newer derivatives, which will come to that later. Whereas the synthetic progestins, they have high oral activity, and that is why they have been developed. Now, if you see, synthetic progesterones can be basically divided into two types, depending on how they are derived. So, if they are progesterone derivatives, that means, I will use a pointer. Right. So the progesterone derivatives, if you see the structure, they have 21 carbon atoms in it. Whereas there is this 19 not testosterone or the testosterone derivatives, which have 18 carbon atoms in them. So that is a basic difference. When we differentiate the progestins, subsequently, we will see that the structural classification is based on these number of carbon atoms and the origin, like which is the precursor molecule for that. So synthetic progestins can be classified into based on two types, like either based on the structural properties or into generations. So we have 4 generations of progestins available now, and these are based upon when the group of progestins were introduced into the market, regardless of whatever structural derivation they have. Okay. So coming to the first category, that is, let's classify progestins based on the structural variation that we have. So here we can classify them into 2 varieties, the progesterone derivatives and the 19 not testosterone derivatives. So basically, either the precursor is progesterone itself or if they are derived from the testosterone molecule. So the progesterone derivatives, as we all know, are medroxyprogesterone acetate, megestrol, dihydrogesterone, hydroxyprogesterone caproate, and the newer one, normegestrol. Whereas the 19 not testosterone derivatives are again subclassified into 2, the estranes and the gonanes. So I will come to that later. So estranes are the norethindrone, lenestrol, and allosterol, whereas gonanes are levonorgestrel, bezogestrel, norgestimate, gestodine. So here basically the substitution is at the C13 molecule. So gonanes will have an extra ethanyl group on the structure at the C30 level. And then we also have antiprogestins like mifepristone and selective progesterone reuptake receptor modulator like ulipristol, which are used in recent times. I hope this is visible.
Yes.
I mean, because the fonts are small, but then this is, a very interesting slide. Here you can see the classification very clearly. So on this side, we have the drugs or the progestins which are derived from testosterone. And here we have the drugs which are derived from progesterone, right? From progesterone, again, we have pregnanes and norpregnanes. So pregnanes, we have different pregnanes like medroxyprogesterone, then cyproterone, we have seen already. So depending on whether there is an acetate group present or not, we have different types of pregnanes as well. Similar is the case for norpregnanes, and the most important drug here in this category is normegestrol, and which has been recently introduced and has been used also quite sufficiently now. Coming to the other category, which are drugs which are derived from testosterone. So If you see in all these drugs or in their structure, you will see that there is a common molecule or common structure which is there, which is the delta 4,3 ketosteroid structure. And this is present in all molecules, and that is why they're labeled as progesterones, or all progesterones would fall under that because of the virtue of this structure. But there are certain modifications in this. So, for example, testosterone, the progesterones which are derived from testosterone are mainly classified as estranes and guanines. Now, in guanines, if you see, there is a extra ethylene group which is present or at C13. So these are also called as ethylenated progesterones, right? Whereas in estranes, you don't have any such ethylene group on the C13, right? Again, there is a drug called as Denogest, which is not ethylenated at all, right? Now, we have already seen estranes, different types. We have seen the names, and we have in addition tubulon, ethnidiol, linestrol. So all these fall under estranes. Under guanines, we have desogestrel, gestodine, norgestimate, levonorgestrel, and norgestrel. There is another variety of drugs. So these are the again newer drugs which are spironolactone derivatives. Now, how do they differ from other drugs? Is that these are prodrugs. By prodrugs, we mean that they themselves would not have the progestin activity, but they are then converted in the body and to progesterone derivatives. Hello, is someone speaking something?
No.
Yeah. So that is how they will act. So these are prodrugs. And by virtue of being spironolactone derivative, we will see the anti-mineralocorticoid action as well for them. Okay. So one by one, let's see these drugs. First, we focus on the pregnance of the progesterone derivatives. Okay, here we had seen these. This is the category of pregnance. Okay, so these are almost pure progestins, and they have weaker anti-ovulatory action. Right. So primarily used as adjuvants to estrogens for hormone replacement therapy in postmenopausal women, threatened abortion, endometriosis, etc. Then the newer drug, norpregnane or nomegestrol is the drug here. This has weak anti-androgenic property, less anti-ovulatory, and strong anti-estrogenic effect on endometrium. And thereby now, it shows good potential to be used. And adverse effects on lipid profile and glucose tolerance also appear to be lacking with this drug. So it could be surely considered. The other variety, that is the testosterone derivatives, 19 not testosterone derivatives. The older ones, estranes, mainly the norethindrone or linestrenol, as examples. So these drugs, being testosterone derivatives, they obviously have weak androgenic properties, right? In addition, they have additional weak estrogenic properties. They are, as I said, weak androgenic properties, and they also have anabolic properties, right? And as far as the anti-ovulatory action is concerned, they are quite potent anti-ovulatory agents, right? So these are used primarily in combined contraceptive pills along with estrogens. The other variety of 19 not testosterone derivatives is gonanes. Examples we have seen earlier, but listed here again: levonorgestrel, besogestrel, gestodine, norgestimate. So here, as I said, gonanes have a 13-ethyl substitution on them. So these are basically estranes, but with a 13-ethyl substitution. So that is why they're called gonanes. And as I said, these are prodrugs converted in the body to active metabolite, which will show its progesterogenic effect. And they're very potent progestins. So a very low dose is required. Being very potent, low dose would be required. For example, and also they are very strong. They have strong anti-ovulatory action. So if you see one example, gestodine, it inhibits ovulation at as low as a dose as 40 micrograms per day, right? So that potent is the drug of this category. And with this, because you can reduce the dose of progesterones, so it allows reduction of ethinyl estradiol dose as well, and when they are combined together, and thus decreasing the amount of side effects that it would have. In terms of androgenic activity, gonanes are, compared to estrogens, gonanes have little or no androgenic property. So in fact, they do not antagonize the beneficial action of estrogens on both lipid profile and are really preferable in women with hyperandrogenemia. So this is again a newer class of drugs. A lot of newer drugs have been added, in the past few years. So gonanes started, they were introduced somewhere in 1951, and many newer drugs were added, and they found that definitely it has low androgenic potential. So that is why more preferred. So in terms of structure activity relationship, and if you try to correlate the activity, right? So if you see the normal natural one, progesterone, basically this is a pregnant, and there are structural features as we saw earlier, C21 structure, and this is a natural drug with a poor oral bioavailability. That is why progesterone is not given generally orally. We will come to the micronized versions which have come now, which can be given orally, but otherwise progesterone so far what was available was not for oral use, because it neither was getting absorbed well and was also getting degraded in the liver. The other variety is medroxyprogesterone acetate. This is again a pregnane, and this has C6 has a methyl atom, and 17 alpha acetate is also there. That is why it is medroxyprogesterone acetate. Now, by virtue of this change, what has happened is there is high oral potency. Okay, so the drug is very potent when given orally, and it also has a long half-life. So it stays in the body for also a longer duration of time, and that is why you will see that this drug is quite preferred or widely used. Norethistran is a estrane. Now we are coming to the testosterone derivatives, right? So norethistran is an estrane, first generation, so the older drug, and it also has an ethinyl group at the C17 alpha, and it does have this delta 4,3 keto structure of steroids, right? So in terms of potency, it has moderate potency, but since it's a testosterone derivative, it also has some androgenic properties. Levonorgestrel is another drug, and this belongs to the gonane group. We have seen now the gonane group, and these are the newer ones, or the third generation molecule. And here, as we saw, gonanes means there is an ethyl group which is added to C13, and thereby there is high potency, and the androgenic effects are also minimal. The last variety, that was the spironolactone derivatives. This is drosperinone, right? This is non-ethylated and spironolactone based. So this has again a lactone ring in it, and more or less the structure remains the same because we require a ketosteroid in it, right? This drug has a strong progesterone activity and is anti-androgenic, as well as has again anti-mineralocorticoid action as well, because spironolactone is a anti-mineralocorticoid drug. So that is why it exhibits anti-mineralocorticoid action. So that was the classification we saw, which was based on the structure activity or the structural changes, right? There's another classification which is based on the generation. So basically, as and when they were developed, so accordingly they were grouped into various generations. The first generation drugs are the older ones, hydroxyprogesterone or medroxyprogesterone acetate, and these are the earliest developed. primarily used in hormonal therapies, and they have as anti-estrogenic properties as well. Second generation drugs, norethindrone and norgestrel, they exhibit better bioavailability and potency compared to the first generation ones, and these are now commonly used in oral contraceptives. And third generation drugs are desogestrel, norgestimate. These have fewer androgenic effects while maintaining their contraceptive efficacy as well. So again, they are used in contraceptives, oral contraceptives. Last, the fourth generation, as we saw earlier in the previous slide, drosperinone. This has anti-mineralocorticoid properties and often used in combination with estrogen in birth control pills. So if we try to club together the classification as to both generation-wise classification as well as structure-based classification. So here it is. All the drugs are mentioned here, and here are the different structure-wise classification. But at the same time, you will see the generations. So if you see the gonanes, so they are from the higher generations, second, third, fourth generations. You will see gonanes as well as the spironolactone is derivative is fourth generation, and a few norprogesterone derivatives, especially the norgestrel, nemogestrel also is generation 4. Okay, so we have both the classifications together, so we know which are the newer ones and what is their structure and what would be their activity. Just to club together their activity here itself, if you see the progestational activity, again for 19 not pregnant, you have more of progestational activity, which are the newer pregnancy or not pregnancy. Then you also have anti-estrogenic activity with these drugs. Gonanes have some degree of androgenic activity, but there are certain other anti-androgen, the other drugs which we saw under gonanes, which have anti-androgenic activity. Even drosperinone has comparatively lesser anti-androgenic activity as compared to the other gonanes. Drosperinone again has anti-mineralocorticoid activity, and medroxyprogesterone acetate has in addition glucocorticoid activity. So these are the activities that you see with most of the progestates, right? So let's see now the pharmacological actions of these progesterone. So on which systems and where do they act, and what is the action of progesterones on our body? So in terms of in general, if we see, we all know that progesterone, it's required, it prepares the uterus for nidation as well as for maintaining pregnancy, right? And here, it prevents endometrial shedding, decreases the uterine motility, and also it inhibits immunological rejection of the fetus because it has produces cell-mediated immunity, right? It depresses the cell-mediated immunity and the T-cell function. So that is why it inhibits the immunological rejection of the fetus as well. And that is how it maintains the pregnancy. Other actions, if you see now, like if you see system-wise or organ-wise actions, on the uterus, progesterones, they produce secretory changes in the estrogen-primed endometrium, right? This could be, anything from hyperemia or tortuosity of glands, increased secretion can happen. And there is also epithelial proliferation that happens, that is halted. So epithelial proliferation is halted with the help of progesterones. If you take off the progestational support, then it leads to mucosal shedding during menstruation. Second action on the uterus, which is seen, if you continue the progesterone, especially when pregnancy occurs, then you will see that, when pregnancy occurs, the continued action of progesterone would be there. And then you will see that there are decidual changes as well in the endometrium. So by decidual changes, I mean that there would be the stroma enlarges and it becomes spongy, and there could be atrophy seen. Sensitivity of the myometrium to oxytocin is also decreased. So these changes will help in, as I said earlier, in the nidation and maintenance of pregnancy. So there's endometrial receptivity, as well as it favors embryo implantation. In terms of the action on cervix, so progesterone converts the watery cervical secretion induced by estrogens to viscid, scanty, and cellular secretion. So this viscid secretion now makes the sperm penetration difficult. So it is hostile to sperm penetration. Thus, here we see it thickens cervical mucus. On the vagina also, it induces pregnancy-like changes in the vaginal mucosa, and leukocyte infiltration of cornified epithelium then occurs. In the breast, you will see that there is proliferation of acini in the mammary glands, and also the cyclic epithelial proliferation and turnover occurs during the luteal phase. But so together, if you give along with, together in concert with estrogens, it prepares the breast for lactation. And if you towards the end of the pregnancy, when withdrawal of these hormones after delivery, this will cause release of prolactin from the pituitary, and thereby it will stimulate the milk production, and milk production starts. Here we have already discussed this, and I am sure everybody is aware of this, that how does progesterone have its action on the post ovulation, as well as the secretory changes that are there, as well as the other actions that we saw. So I'm not going into detail of this slide. This was just to sort of summarize together the different actions, especially during the menstrual cycle and post. Other actions of progesterone on different systems. Now, we will see that in CNS, only if the circulating concentration of progesterone is high, as you see during pregnancy, then it may have sedative effect, or it may even affect mood. In terms of respiration, it can stimulate respiration, but only at relatively higher doses, and again, which happens generally during pregnancy. Also, this elevates the body temperature slightly to around 0.5 degrees centigrade by resetting the hypothalamic thermostat and increasing the heat production. Okay, this is induced, and so generally you see that during the luteal phase, there will be slightly higher body temperature, like 0.5 degrees higher. In terms of action on various metabolisms, first the carbohydrate metabolism. Prolonged use of progesterone will impair glucose tolerance. Okay, but again, it does that in some women, not necessarily in all. So, but only on prolonged use, right? Then progesterones with androgenic activity, like as we saw the testosterone derivatives. These can raise the LDL levels and lower HDL cholesterol levels. And these may reduce the beneficial effect of estrogen, especially if used concurrently, like in contraceptives or in hormone replacement therapy, right? Then the micronized oral progesterone formulation. So as we were discussing earlier, the only oral progesterone formulations nowadays, they are available, the micronized oral formulations. These are also referred to as natural progesterone. So these are not shown, they do not interact with the beneficial effect of estrogen on LDL and HDL cholesterol. So again, they are preferred because of their beneficial effect on these, on the cholesterol. Action on the pituitary. So as we all know, progesterone is a weak inhibitor of gonadotropin secretion from pituitary, and it exerts the negative feedback at the level of hypothalamus and reducing the frequency of GnRH, so gonadotropin releasing hormones from the hypothalamus. So there is a negative feedback. If the circulatory gonadotropin levels increase, then there is a negative feedback on the hypothalamus, and then it reduces the levels. Administration of progesterone during follicular phase, it suppresses the pre-ovulatory LH surge and thus prevents ovulation. So if it is administered during the follicular phase. Gonans, they also have effect on the GnRH. They suppress the GnRH markedly and thus have potent anti-ovulatory effects. So if we try to just summarize together the actions of progesterone, so we know that progesterone could be released here from the corpus luteum or even from placenta, and progesterone, the actions on the endometrium, it will prime the endometrium for embryo implantation, and it regulates the luteal phase of ovulation in the menstrual cycle, and as far as the reproductive system is concerned, again, the uterus, it maintains the uterine presence when the pregnancy, for the pregnancy to be, positively favored. In the breast, as we saw, it causes development of the acini, so lobular and alveolar development happens, and thereby it also helps in the milk secretion from the breast on withdrawal. Right. Also, it's a precursor for various hormones in the body. So that is also one more effect of progesterone. Let's come to the mechanism of action. So in terms of mechanism of action, progesterone has its own receptor. It acts on progesterone receptor. And this receptor has very limited distribution in the body, confined mainly to the female genital tract, breast, CNS, and pituitary. And that is why when you saw the actions were on these organs. Right? So progesterone receptor is normally present in the nucleus, inside the nucleus of target cells. Many receptors you would see on the cell surface or on the cytoplasm. But this receptor is present within the nucleus of target cells. And estrogens generally are shown to increase the density of progesterone receptors, whereas progesterone, however, represses estrogen receptors and enhances local degradation of estradiol, in fact. So if you see this diagram here, you will see that this is the cell membrane and here is a progesterone. So once the progesterone enters the cell, this is the nucleus, it goes to the nucleus. Inside the nucleus, you have the progesterone receptor. So it binds to the progesterone receptor, and thereby there are changes which are then seen. So this undergoes dimerization, and it attaches to, because of this, what is formed is it attaches to the progesterone response element, also called as PRE. So the progesterone now attaches to the progesterone this entire dimer attaches to the progesterone response element. And this in turn then causes some genetic changes or regulates the transcription through coactivators, and thus mRNA is released, or with the alteration in the target genes and the transcription, and thereby this is then released, which then causes the protein synthesis and the biological effects that we have seen. Okay, so basically the activity is all inside the nucleus and through the progesterone receptor, and it converts into progesterone receptor element, and thereby it regulates transcription of genes. Okay, let's move to pharmacokinetics. So progesterone generally it's inactive orally unless specially formulated, like we saw in the micronized oral particles that are available now. And this is inactive orally because it has a high first pass metabolism in liver. So because it passes to the liver, and there is a lot of metabolism that happens inside the liver, the drug is not available to enough quantities in the blood, and thereby it does not produce action to the required extent if given orally. That is why it is more significantly inactive actually when given orally. So the preparations for progesterone which are available are generally the injectables, and it's injected IM. Hello? Yeah. So these are injected IM in oily solution. And once you give them IM also, it is very rapidly cleared because it has a very short half-life. It's only 5 to 7 minutes. However short the half-life be, but you will see that the effect of the drug, although the drug is cleared from plasma, but yet the effect that is produced remains for a longer period. Okay. And as I told you earlier, it degrades near completely in the liver.
Ma'am, sorry to interrupt you, but last 5 minutes for your talk, ma'am.
Okay. So the other formulations that are available are the micronized formulation of progesterones for oral administration. Of course, micronized, so microfine particles are suspended in oil and dispensed in gelatin capsules. Now, because of that, what happens is the absorption occurs through lymphatics, and thus the liver is bypassed, and that is why the bioavailability, it can be used orally, although bioavailability is low, but effective concentrations are still attained in the body. And most of these synthetic progesterones are orally, the other synthetic progesterones, they are all orally active. And here is the half-life ranges from 8 to 24 hours. So they have better and sustained action as compared to the other drugs. We have the injectables as well. So only the long-acting progesterone only injections are in use now. And we have DMPA, and also we have available as Depo-Provera. Then we also have norethindrone enanthate. Okay, I'm not going into the details of this. We also have the implants like Norplant, Progestasert here, and these are implanted under the skin, and slowly the drug is released over 1 to 5 years. So they are either biodegradable or non-biodegradable. So we have implants as well. These are the different progesterone preparations that we have, along with the dose and the preferred route of administration and the dosage schedule. So this is how they are available. Even the oral progesterone in the micronized form, it could be given into 100 to 400 milligram OD, and these are the various drugs which are available in market. As far as the uses are concerned, progesterones, they are used as contraceptive, hormone replacement therapy. They are used for dysfunctional uterine bleeding. Okay, I'll go to them directly. So in terms of contraceptive mechanisms, progesterone exerts both central as well as peripheral action, due to which there is, it favors contraception. So central action, of course, it inhibits the pituitary gonadotropin secretion, thereby suppressing the ovulation. It also reduces FSH, LH directly through hypothalamic action. And peripheral action, it increases the cervical mucus viscosity, as we saw earlier, suppresses endometrial mitotic activity, decreases fallopian tube contractility, and promotes premature secretory transformation. Thereby, by the virtue of these actions, it helps in achieving contraception. These are the different oral contraceptive preparations which are available in market. These are the combined pills, phase pills, postcoital, and progesterone only pills. These are the different progesterones which are used along with combination of estrogen. And here are the dose and the brands which are available. So, all these different combinations are available for contraception, and they have varied activity on FSH inhibition, LH inhibition, anti-ovulatory effect, cervical mucus, as we saw. And here is the difference that you can check. So in terms of uses, it's used for hormone replacement therapy to counteract the risk of inducing endometrial carcinoma. Right? And progesterone derivative lacking androgenic activity are preferred here for hormonal replacement therapy. The other use of progestins is DUB, that is dysfunctional uterine bleeding, and the progesterone is relatively used in relatively large doses. So medroxyprogesterone or norethindrone is preferred, and this promptly stops the bleeding in this condition. Okay, subsequently, you can give cyclic treatment at lower doses, and which regularizes and normalizes the menstrual flow. and progesterone with inherent estrogenic activity is generally preferred here. In other uses for endometriosis, you can give continuous administration of progesterone, and this causes anovulatory hypoestrogenic state by suppressing the GnRH. And there is also direct action on the endometrium, which prevents bleeding in the ectopic sites.
Madam, if you could please summarize now.
Yeah. So it can be used in premenstrual syndrome and threatened habitual abortion, endometrial carcinoma also. This is the summary. Like it could be used in all these various conditions that we have discussed so far. Just briefly, the adverse effects. So it could cause headache and all others, breast pain, basically because of the engorgement, and fluid retention, abdominal cramps, depending on the drug which is used. So if you see the newer progesterones, newer drugs, they have, or the newer generations, they have decreasing order of androgenic side effects starting from the first to the fourth generation. So to summarize, the older generation ones they bind to multiple receptors and they have broad range of biological effects. They have increased adverse event profile and they are less selective to their action. Whereas the newer ones, especially the drospirenone or all the other newer ones, they have greater selectivity towards the progesterone receptors and they minimize the off-target effects, improve safety profiles, and thus have targeted therapeutic actions. Right. Thank you.
Thank you very much, Dr. Ragini. I know the topic was very exhaustive. It is actually 50% of OBGY, we can say. So,
it was.
Yeah, it was, but you beautifully really told us how pharmacokinetic is tissues is root specific. Can you hear me?
Little louder, please.
Yeah, and pharmacokinetic is root specific, dynamic is tissue specific. Whole WHI study we know was because of bad selection of progesterone, and you beautifully told us that how generation is not important, the root and the molecule is important. Thank you very much for all the inputs you gave us. We are the clinician, we are indebted. Thank you very much.
Well, I will stop sharing my slides now.
Thank you, Rajni. Excellent presentation. Really enjoyed it. I just had one doubt. We used to always say that the action in contraception is because of thickening of the cervical mucus with progesterones, and it's the estrogen part which inhibits ovulation. But is it the newer ones which have more inhibitory action on the ovulation?
Yeah, if you see actually, the newer drugs, especially the gonins, which are, the newer ones, third generation, fourth generation, they have strong anti-ovulatory action.
That's why I think it is now generalized, but we were always taught in these, two different actions, estrogen action and progesterone action, like that.
Yeah, actually, progesterones are the most important part in contraception. Estrogen is added only to enhance the effect of progesterone in contraception. But in hormone replacement therapy, estrogen is the main hormone, whereas progesterone is added to reduce the side effects of estrogen. So nowadays, the newer progesterones are there, which have got complete action at the CNS level. So, they not only affect the cervical mucus and the endometrial lining, they are also effective in ovulation inhibition. That's why we have only progesterone only pills also that we can give for contraception.
Just one message to the gynecologists who are all listening. The newer ones have got very less side effects, but the thrombotic properties are more. We must always remember that deep vein thrombosis is double that of the conventional drugs. So we have to be careful when we are selecting them.
Yeah, true. And even for carcinoma breast, I think some newer studies have implicated the newer progesterones. So we can give, but we should not give it very long term.
Yeah. Now, basically, what I feel wonderful inputs by Geeta and Purnima. I always actually practice to put a checklist whenever I prescribe any hormone. I put a checklist in patient's file. It's always better so that at least they understand what are the untoward effects and what care one need to take in a particular patient. As Purnima was telling about the deep vein thromboembolic phenomena. Yeah, good. Thank you very much. Yeah, I think we can now listen to yes,
Danny.
Daliwala. Yeah.
Madhuri Joshi to please introduce our new speaker.
And
May I have his
Mm,
CV, please?
need the
I
screen.
know that he is attached to Jaslok Hospital and he's practicing in the South Bombay. He has also nursing home there. And
Danny has had his training at St. GS Medical College and he has a very thorough understanding of OBGYN. That's why I picked him to have this topic.
very good topic, game changer topic. So let's listen to Dr. Danny Laliwala.
So thank you very much. And madam, thank you very much, Satoskar madam, for inviting me. So I am going to have a brief presentation on what are the newer routes of delivery of progesterones. So basically, first to understand what are the new drugs available, I'll just tell you in very short what is progesterone and what are the drug delivery systems now and why they need to be changed. So progesterone, like our madam has already explained in detail, that it increases the secretory activity of the endometrium, which will allow implantation of the fertilized ovum. So varying levels of progesterone, it can cause headache, palpitations, vaginal dryness, breast tenderness, and progesterone is used for a variety of problems in OBGY like menstrual disorders, uterine bleeding, contraception, menopause, in obstetrics for threatened abortion, recurrent miscarriages, threatened preterm labor in singleton or in multiple pregnancies. And so the various routes what you're using right now is oral, micronized progesterone, dihydrogesterone, gels, and injectable ones. So the oral route has low bioavailability because of the quick metabolism in liver and intestine. The intramuscular and the vaginal route will decrease, they'll have a decrease in the first pass metabolism and therefore more concentrated are present at the targeted site. And micronized progesterone vaginally, 10 times it is more concentrated than intramuscular because of the vaginal vascularity. So why we require new routes of delivery? To improve bioavailability, to increase the patient compliance, reduce the systemic side effects, avoid first pass metabolism, and long acting systems will reduce need for a daily adherence. So focus is on long acting, user controlled methods, minimum doses for HRT, and usage in obstetrics for preconception as an IVF, and also in all the trimesters of pregnancy. So I will be discussing one by one what are the newer ones, and I'll be using few trade names also just for a better understanding. So we have these long-acting vaginal rings available. Now these are various, like earlier in India also we used to have these estrogen plus progesterone available, but they did not run very well in India. Now abroad there are certain contraceptive vaginal rings available which can be used from 3 months to 1 year. One of them is aloe vera. So aloe vera can be used for 1 year where you use it for 21 days, where you have to remove it for 7 days. Again, it can be sterilized and reused. This contains segestrol acetate, which is 103 milligram. This segestrol acetate is derived mainly from the progesterone and not from the androgens or anything. So it has high anti-ovulatory potential. It lacks androgenic and glucocorticoid activity at contraceptive doses and very little thromboembolic phenomena. The other ring which is used is Proger ring. This is mainly in Latin America and they promote it for breastfeeding women. So 3 months continuously you can use it. After 3 months you can use another ring and it can be used up to 1 year post delivery. And this releases progesterone hardly around 10 milligram per day. There are other Nesterone only rings available which can be used 3 monthly and 6 monthly. So these are only progesterone only rings. So again, no side effects of the estrogen. There are other rings available which contain Nesterone as well as ethinyl estradiol also, which can be again used 3 monthly or up to yearly. Another group is vaginal gels and inserts.
Now, these gels and inserts, they will reduce the leakage inside. So these inserts, when you insert inside the vagina, they will form like a gel over there. And one of them is the endometrin. So endometrin, it can be used 2 or 3 times a day. The dose is 100 milligram, it is available. So in IVF, it increases implantation and decreases miscarriages. And it has also been commonly used to treat amenorrheas by inducing menstruation. These are very simple to be used by the patients also. This Implanon we have been using in India, Implanon NXT, which releases etonogestrel. This is very easy to insert, very easy to remove. It will last for around 3 years. The newer ones which are available in the world is one is Nexplanon, then you have Jadel and you have Sino implants. Jadel and Sino implants, there are 2 rods and they can be used for 5 years and 4 years respectively. The DMPA injections which we were using right now for contraception, they used to be very painful. So nowadays, there are subcute injections available. We have in India which is available, Cyana Press, and it is not very expensive, around say 500 rupees it costs. But this has also been very useful for the patients. Then you have the advanced intrauterine systems available, which we know Mirena everybody has been using, but sometimes Mirena causes it is painful while inserting, may require anesthesia. So these newer ones like Skyla, Kylina, these have very small frames and they are very narrow inserters. So can be easily inserted in the OPDs. You can use them, and they are used even in nulliparas. So Skyla is used for 3 years and Kylena is available for 5 years. Then you have transdermal gels and patches available, which is estrogen and progesterone. These are basically used for HRT. There are no thromboembolic risks associated with them. Reduces menopausal symptoms, and more important, even these, they provide good bone health. And then the next one is a metered dose transdermal system. So these are the newer ones which are under development. They can use metered dose aerosols, pumps, and sprays. So all this is through the skin. So transdermal patches will form a film on the skin, and there are microemulsion based microneedle patches. So these are very good for skin diffusion. Then you have the newer ones also, electrospun fiber fabrics, vaginal inserts of films that will deliver progestins in combination with other agents like the HIV prevention drugs can be incorporated inside it. So these are used for dual protection. And also these inserts and films can be used for threatened preterm labor and in HRT. There was an interesting paper, even this was from Mumbai and Pune, recent advances in progesterone delivery systems by the pharmacology department. And they have also said that nano carriers are being developed. So they are lipid carriers and polymeric carriers to increase solubility and the bioavailability. So progesterone-loaded nanofibers, they coat the pessaries and they can be used for PV insertions. And it seems they have doing trials for threatened preterm labor. And electrospun mats of cellulose acetate are used for HRT, which can be used for around 90 days. So newer methods are being developed for easy use. And thank you so much.
Wow, so much of new stuff. Very
It was a short one.
Very interesting.
Yeah, but very interesting, Danny, because these
thank
routes
you.
are absolutely a new one, and suppose they come actually in the clinical practice, it will be wonderful actually the change. Yeah, good.
Out of the box and into the vagina.
Out of the box. Yeah.
That's superb, man.
Very true.
Thank you.
Thank you.
Very
Wonderful.
much, Dr. Jenny. It was really, progesterone is not a single simple drug now. So many routes have really, I hope that all of us will get it in India obviously the rates are not very prohibitive, but the more we use, the more we can give benefit according, we can really custom made it according to our females use, like Marina, low dose. Sometimes if it is definitely every single thing, whatever new has come up, have one niche for its use. So really you took us really through all good range, and the trade name, what brand and the pictures you showed, really that made us to like it has ingrained in our now
State
mind
of
that
mind.
there are so many
Thank you
other
so much.
options are available. Thank you so much.
Thank you so much, madam.
Yeah, and thank you Dr. Purnima and the team for giving me this opportunity.
Thank you all.
Yeah.
Dr. Milind, Dr. Purnima, thank you for giving me
Yes.
this opportunity to chair this session. Wonderful session.
They very well actually moderated Geeta and Madhuri. Wonderful. Good, good.
So,
Divya?
madam, should we start with the panel?
Yes, yes.
Yeah, Divya, if you could just, yeah.
Yes, ma'am.
So Milind had said, he said that I was Yashoda. So now we have the Krishna and the Balram here who are going to moderate.
Wonderful.
So, without delay, my co-moderator Ruchika. Divya, if you could just introduce me and Ruchika in two lines.
Yes, ma'am. Moderators for our panel discussion are Dr. Priya Vora, Managing Council member of MOC since 11 years. She is a youth council mentor since 8 years, currently the president of Mumbai Menopause Society and vice president of AMWI Mumbai branch. She's been a convener for various conferences, outreach, and PG teaching programs. She has contributed various chapters in journals and books and is the editor of the books Drugs and Ops in Gynecology and editor of the book on Menopause Update, Evangel Publishers 2025. I welcome you, ma'am. Our second moderator for the evening is Dr. Ruchika Garg. She is currently the professor in Department of OBG at SN Medical College, Agra. Editor-in-Chief of Journal of Midlife Health, Executive Editor Journal, and SAFOG, that is South Asian Federation of Obs and Gynae. She has been an editor of the 19th edition of Shaw's textbook in gynecology and has received various awards like Korean Foxy Future Award, Nimish R. Shelat Award, been recipient of Indian Book of Records 2024 for vaccinating maximum number of medical students against cervical cancer. I welcome Dr. Ruchika.
Okay, without delay, I would like to invite my panelists. Our first panelist is Dr. Uma Sawant. Madam has more than 30 years of experience in practicing OBGY. She is passed from the MBBS from said GS Medical, and special field of interest is fetal imaging. The second is Nidhi Shah. She's a consultant at the in Jaslok Hospital, and she's a secretary of AMWI Mumbai branch with a special field of interest is colposcopy. Dr. Navneet Desai. She is also a practicing consultant. Committee member of MOGS and second joint secretary of MOGS. Dr. Sudeshna Ray, she is attached to Jaslok, HN Reliance, Preach Candy, Saifi Hospital, and she's a certified gynec robotic surgeon. Dr. Ekika Singh, she's our IVF consultant on the panel, and she has a diploma in reproductive medicine from London as well as from Germany. She is an IVF consultant, director of Sharda Narayan Hospital in UP. And Dr. Neelu Singh, she's a consultant pediatric neurologist at Hinduja Hospital and Jupiter Hospital. She has more than 20 years of experience in epilepsy management and pediatric neurology, and she has more than 30 publications in peer-reviewed journal. I would like to welcome all our panelists, and I would request Ruchika to just share the presentation, please. Can we both have slide control from the team?
Yeah, you just say at the outset, I would like to thank Purnima madam and Dr. Milind Shah sir for this opportunity. So without wasting time, let us start. Dr. Priya, please
Yeah.
start. Yeah.
So progesterone, a key hormone in reproductive physiology, but there is a rising concern because of the overuse and irrational prescriptions. We see every gynecologist prescribing progesterone just in case for every case of a spotting. It's like a low grade abuse of this drug. So we need to definitely go into evidence-based practice. Luteal phase support in ART, there is enough evidence on the use of progesterone for prevention of preterm births, endometrial protection with estrogen therapy, in AUB cases, endometriosis, contraception in the form of the LNG intrauterine system. Next, please. The common misuse is there many a times in all the pregnancies where we are giving blanket therapy. It's like a routine use, unnecessary use in the normal luteal phase also, empirical use in infertility without an indication, or over prescriptions in AUB without the diagnosis. Next. So now we start with this first case. In our day-to-day practice, it's a very common scenario where a 28-year-old, 7 weeks pregnant patient, and she complains of spotting or bleeding. And she walks into Dr. Sudeshna's clinic. So Dr. Sudeshna, what would your approach be in such a case? If you could just tell us the important evidence-based guidelines for threatened miscarriage.
Sorry,
Yeah.
can you hear me?
Yes, yes, you're audible.
Yes, yes, Dr. Sudesh.
Yes, yes. So, sorry, can you go back to that case again? Is it
Yeah,
7 weeks of bleeding?
yeah.
Is
So
7
she has
weeks
come to you
bleeding?
with 7 weeks and there is bleeding.
This was
Now,
She
this
was given
patient
high dose
actually,
progesterone. Yes,
yeah, she was
yes,
given high dose progesterone without a ultrasonography.
right.
And then it turned out to be a missed,
An
it was an
ectopic.
ectopic pregnancy. So what is the guidelines of how we should go about in a case of a threatened bleeding?
So, in fact, if you
This
see the
was an
evidence
abuse
that
of progesterone.
yes, it was if you see the evidence doesn't talk about progesterone effective in reducing preterm labor without or in reducing threatened miscarriage without evidence of a short cervix or without an evidence of a ultrasound guided short cervix or so
Dr.
if
Sudeshna, we
you
are talking about threatened miscarriage right now. Preterm
yes
labor we'll be discussing later.
no so
And the
threatened
panel is
miscarriage
open to
also
all the panelists. Yeah.
yeah, so the threatened miscarriage also, I would definitely not before an ultrasound. An ultrasound has to diagnose the intrauterine pregnancy first. And why is the threatened miscarriage? What is the kind of, is it a genetic abnormality which is causing a threatened miscarriage? Where is just because she's bleeding does not mean that it is a threatened miscarriage. It can, the bleeding can be of various reasons. So I will not approve giving a progesterone without doing a sonography. And even if it is a sonography, uh, if she doesn't have any history of previous miscarriage, then I would not start on progesterone just because of
I
mild
think
bleeding.
that's a very important point, Sudeshna. You brought out that without an ultrasound, we shouldn't start. Even the NICE guidelines 2021, it just says that only when we have, said that there is an intrauterine pregnancy is confirmed, if there is at least one previous miscarriage, vaginal bleeding in
Yeah.
early pregnancy, and 400 usually milligram twice daily is the dose. Now, Shreya, I just wanted to ask you, many a times most of the guidelines say that there is vaginal route, but our patients, when they have bleeding practically, they are little hesitant to put the medication. So how do you counsel and how do you go about that?
Yeah, definitely. So first thing is counseling here, I was actually coming to that because everybody is scared. See, I know that guidelines say 2 miscarriages, 3 miscarriages, 1 miscarriage, and she's bleeding, you give. But for a patient who's coming for the
Right.
first time
Yes.
and she's a primigravida and she starts bleeding in pregnancy, she is shit scared. So
Yes.
basically, what we need, that counseling has to start from there. The second most important thing is examination. We are forgetting clinical examination here. Clinical examination of the patient is important. I'm sure if it is an ectopic pregnancy, we are going to get cervical motion tenderness. We are going to get, pain in the fornices. So once we are detecting that if the uterus, a 7 week uterus is going to be, it's quite bulky, and we will be able to make out whether the uterus will clinically at least have a pregnancy or no, and whether we are failing a lump. So that is the first. What Sudeshna ma'am very clearly, very nicely said was that an ultrasound. Now, counseling the patient is very important. They do recommend, or rather, they are recommended vaginal, but trust me, with bleeding, counseling patients for a vaginal route is very difficult in an OPD. We need to really tell them that the absorption and the direct availability, bioavailability of the drug when you use it vaginally is much more than when you take it orally. So it depends on how well you counsel the patient, and they do accept once you have counseled them well and you've told them that it is not going to harm, putting a finger inside,
Yes, Dr. Shreya, I would
depositing,
like to add that.
repositing it there.
Yeah.
Yeah.
Yeah,
Can I
So,
apart from that,
that is, we need
dydrogesterone
to.
is also a good option.
Yes,
Dydrogesterone, according to
absolutely.
the FIGO 2023 guidelines, 10 to 20 mg of dydrogesterone can also be a good substitute to vaginal micronized progesterone.
Yes,
And according to the
absolutely.
FOXY guidelines, also in
Yes.
cases of acute bleeding, 40 mg stat
40
as
mg.
and
Yes,
followed by 10 mg 10
Three times.
mg BD
Yeah.
or 20 mg OD. Dydrogesterone is
agreed.
also good and it is having less side effects as compared to the oral micronized
Yes,
progesterone like sedation, etc.
Yeah, that's what.
So
Can I
apart
just?
from vaginal micronized
Yeah.
progesterone, dydrogesterone is also a good option. And I would like to request the panelists to be to the point so that we complete all the
Nidhi.
cases and the audience have a good knowledge at the end of
Yeah.
the panel.
Who wants to add something? Nidhi?
Yeah,
Yeah.
Priya, I
Yeah.
wanted to add,
Yeah.
you just
Sure.
tell the patient two things: the advantages of a vaginal over oral as far as bioavailability is concerned. And second, if you tell them the side effects are lesser when you give a vaginal, sedation is something that many patients complain of, drowsiness, daytime drowsiness, and nausea. If you tell them about these two things, then I think they are very acceptable to the vaginal route as well.
Right.
And
So I think all
moreover,
these
taking just
panelists,
before the sleep so that by the time it's
yeah.
absorbed, that is also
So I think all three of y'all have done quite, have brought out very important points. Even the evidence does say that in the PRISM trial showed no significant benefit when there was no history of a previous miscarriage. 5% increase in live birth rates for women with 1 to 2 previous miscarriages, and 15% increase in live birth rates for women with more than 3 miscarriages. But practically, though guidelines do say 3 and 4, but I don't think any of us wait, even after
So is
one
it
miscarriage.
correct then?
Yes,
The thing
because,
is it
and
correct?
if you don't
If you
start it, the
have
next
no
doctor is
miscarriage,
going
and
to.
if you have no miscarriage,
no.
if
What
you
is
have a slight
yeah?
bleeding, uh, is it correct to start on progesterone?
I
I
Actually,
think
think
actually, we have to go by the guidelines. The ASRM guidelines, guidelines also say that in sporadic abortions, progesterone has no role. Only when there is at least history of one miscarriage and
yes.
vaginal bleeding at present, then it is not that this panel is that don't have to prescribe it empirically to all pregnant women. So
Yeah, go
if
to
it
the
is
next
Absolutely.
slide, Ruchika.
Absolutely.
indicated, then only prescribe progesterone because
Can,
there are certain
yeah.
side effects also. We'll be discussing like intrahepatic cholestasis of pregnancy and others.
Go
Yeah,
into the next slide. Yeah, so
yeah.
no evidence of benefit if there was bleeding, but no previous miscarriage. Previous miscarriage, but no bleeding. Unexplained asymptomatic recurrent miscarriages. Even the PROMISE trial showed no significant benefit for this group. So, yeah, go to the next slide. So we need to follow evidence-based protocols and use either important guidelines
About the
like
use
the
of progesterone in
ACOG, PIGO, extra, and individualize the treatment and avoid blanket prescriptions. Even the Cochrane database does show that vaginal progesterone increases the live birth rate for women with a history of one
Of
or more
miscarriage.
previous
Yes.
miscarriage or a bleeding.
Okay,
Ruchika, you can take this.
one thing, Priya, I just wanted to ask this because the panel is a very practical discussion going on. So you have a patient coming at 8 weeks who has been given progesterone from the very beginning, even after doing a sonography, and you find no reason for giving the progesterone. What is your practical advice on stopping that progesterone at that point in time? Will you stop
Yes.
it or will
It
you
should be,
continue it?
if there is a threatening miscarriage, acute
You
bleeding
continue.
till 7 days, dydrogesterone, till 7 days after the bleeding is stopped, dydrogesterone should be given. And the one important thing is till luteoplacental shift is there. Till then only
12
we have to
weeks.
give progesterone. That is 12 weeks or maximum 16 weeks. After that, progesterone
Sure.
has no effect. But in the FOXY guidelines, till 20 weeks, it can be given if it is dydrogesterone. But in all the international guidelines, after
16 weeks, 12 to
luteoplacental
12,
shift,
16.
after
12 weeks.
16 weeks,
12
12
to
weeks, there is
16.
no benefit of progesterone.
Yeah,
To
you can
answer
stretch up
Dr.
to 16.
Sudeshna's question, I think if the progesterone was started empirical and we don't find any of these evidence where we need to start progesterone, and if the patient comes to you, I think we can safely stop it at whatever
Stop it.
gestation is there. Yes, and we can tell them, counsel them, as Shreya has rightly pointed out, explain them that yes, this is not needed. Evidence
Yes,
has shifted, and now, based upon the evidence, it is not needed.
right. Thank you.
Yeah.
Thank you, everybody.
Ruchika, please take this case.
Now coming to the use of progesterone, there's a patient, there was a patient with short cervix. It was less than 20 millimeter. So what will be your, will you prescribe progesterone or will you advise cerclage? And what are the indications of using progesterone in patients with short cervix? Any of the panelists can take this question. Shreya is also there. Dr. Uma is there.
At 20 mm, I think I would prefer, depends on the gestational age of the patient. I mean, how many weeks she is. But I
Yes.
would definitely try to put in a cerclage initially based on the gestational age. I don't know whether she is in preterm labor, stabilize the preterm labor, and then move on to maybe vaginal progesterone. That is what I would prefer to do at 20 mm. Of course,
Yes.
based on what the
Ideally,
gestational age of the patient.
Evidence says that you can use
evidence say
either.
that
Yeah, you can do
You can use
either, but that
either.
is what
both
I
are
would do.
equally effective. Progesterone and
Both are equally
cerclage, both are
effective.
equally effective. We have to discuss the pros and cons, the risk with the patient, and it should be an individualized decision.
Yes. So to add,
So in patients with short cervix, less than 1 inch, we can remember that before 16 to 24 weeks of pregnancy, vaginal micronized progesterone can be given. In the promise trial also 400 microgram BD of micronized progesterone was given. And for prevention of preterm birth, it can be given till 34 weeks of gestation. Though with long-term use of progesterone, incidence of intrahepatic cholestasis of pregnancy have been increased in few studies. So even the same question for this indication, if we give long-term progesterone, there might be certain neurodevelopmental issues in the fetus, but the evidence is not very strong in the same. So we have to be
Can I?
evidence-based. Yeah.
Yes. So can I also this kind of a scenario where there is a threatened miscarriage? I've seen in my practice that there are multiple progesterones being used, and multiple there's evidence of saying that multiple uh, progesterones do lead to more neurodevelopmental problems. So here we are, though evidence says only one progesterone, but in practice, we see multiple progesterones being used. I think that should also stop. Are we there?
I think, yeah. So yeah, especially for the IVF patients, which we'll be taking later on, that they have, I think if Dr. Neelu Desai has joined,
Can I have one small question here?
yeah.
So I just wanted to know now, since we're discussing
Yeah.
short cervix, is there an added advantage, or rather, do we decide whether to use only progesterone or cerclage if we see any funneling of the internal loss? Does the decision change, or we can
Yes.
still use either or?
The funneling means it's the barrier has
Opening.
opened. So
Yes.
there,
I
how
think
much
it's
progesterone
cerclage.
will help? You have to give
So
a
cerclage,
mechanical.
yeah, because we
Yes.
usually go with a cerclage. So I
Yes.
don't think there is any guideline which says we either or. So I just wanted to
So
confirm
it
that.
is
Thank you.
20 millimeters, but with internal os closed. If the
Closed.
internal
Yes.
os opens, then it should be a cerclage. And
Cerclage.
I don't remember the source, but I read somewhere else that you do another sonography after. I don't know if it was in Nicolai's lecture, if I'm not sure, that you repeat the scan after 2 weeks. And then if you see further shortening, that means that your progesterone is not working, so you can put in a cerclage. So I found that a very practical point. But you have to do a transvaginal scan.
Yeah.
Neelu is with us.
Yeah,
Neelu.
purely
Yeah.
With an
So,
empty bladder.
Madam, we want to
Transvaginal
know.
scan with an empty
and
bladder.
transvaginal
Yes, transvaginal.
and
And with an
transvaginal
empty,
sonography.
sometimes, they have this, they
Yeah.
just put in the transvaginal probe, and then with the bladder full, the cervix looks very short.
And you give
And
pressure. Yeah.
yes.
So I
So
think
even
since
progesterone is
Dr.
helpful in
Desai is
short.
with us, the pediatric neurologist, Madam, we will want you to tell us if when we are giving, long-term progesterones or multiple doses as, and many of the IVF consultants give. So what are the pediatric problems? Have you come across things? If you could just tell us for the benefits of the audience.
There has been some associations with autism spectrum disorders, ADHD, even intellectual disability and all. But everything is like assumed. There's no clear, robust evidence proving it directly. But there have been associations with either over or under exposure, which is leading to autism spectrum, seen more in IVF pregnancies in where progesterone has been used. So there has been definite lot of interest in this field, and not very robust data, but some minimal studies which have shown that there is some increased risk of autism,
Yes.
especially ADHD also.
Okay. Yeah. Even progesterone is helpful in short cervix at 18 to 32 weeks of pregnancy also. And even it reduces neonatal outcome also. It lowers the NICU distress syndrome, intraventricular hemorrhage, whatever pregnancies, because it prolongs the pregnancy by means of uterine quiescence. So even if there is mild cervical shortening, not it is between 25 to 30 mmHg, then also both vaginal natural micronized progesterone as well as dried progesterone are effective. They reduces the incidence of late preterm birth also. So this is also the progesterone can be given in varied doses. So these were now, as discussed by Shreya also, in established cases of preterm labor also. This was a study where the preterm labor was arrested of various topetics and steroid coverage was given. And then the patient was randomized to 400 microgram of vaginal progesterone versus placebo. And the median interval from randomization to delivery, it was increased in cases of progesterone group versus control. So for after the uterine tocolysis has been achieved, vaginal progesterone for maintenance doses arrested preterm labor and reduce the preterm delivery rate at less than 37 weeks, 32 weeks, and 28 weeks of pregnancy. So any of the panelists would like to take what is the if you encounter cervix in case of twin pregnancy, then what how to according to the guidelines.
Empirical, there is
Uma,
no
Dr.
role
Uma, are you there?
for
Yeah.
multiple gestation.
Short
I would
Any of
like
the
cervix,
to add
yes.
that
panelists
if
can
there
take.
is
Short
short
cervix,
cervix,
short cervix, yes, you should,
Yes, it
yes,
goes
you
with the
can.
short
then
cervix
we
because of the
can
short
give in twin
cervix.
pregnancy.
Yes.
So only if there is short cervix, we have to start
Yeah.
progesterone. Otherwise, it is
Then
not
we have
needed
to
for
give.
an empirical treatment.
If there is history alone,
Nice.
yeah,
And then
correct, Dr. Navneet.
The voice is cracking
So
actually.
if there is history alone of preterm labor, if there is only history of preterm labor and the cervix is normal, then in twin pregnancies or multifetal pregnancies, progesterone
No,
is not indicated.
no,
Whereas
not
if there is
indicated.
short cervix, Dr. Ekika, what is your say?
that
Because
is
you are
that
dealing
is
with
yes, that is what I
IVF
want.
pregnancies.
Yeah, that is what I want to say. Actually, even in twin pregnancy, if I go off the records and off label, not according to the guidelines, most of the places with twin pregnancy,
Yeah.
many doctors, I mean, they give this option to the patient that would we go for cerclage or should we go for cervical monitoring? But I have seen that if the cervix is shorter side, I have seen these patients going in labor. If they are not given cervical cerclage, this is not according to the guidelines which I'm talking. But according to the guidelines, if it is less than 25 millimeter, we should follow them. We should give them progesterone, and following has to be transvaginal scan till the time you feel it is effective enough. And they should be in, a regular follow up for maybe every 15 days. They should be told about, if they have any excessive discharge, any heaviness, any cramp, any persistent low backache. These all things are all those clinical signs which can be told to the patient. That is the time they have to reach. And I have seen practically
Yes.
many of them go in labor. So we have to be very vigilant with these.
Yes. True. The message is only that routine progesterone to prevent preterm birth in twin or triplet pregnancies is not recommended. We have to follow the cervical length, and if it is less, then go for progesterone.
Yes, that's true.
Because in India, we follow too much of prophylactic things. So, what about ART conceived pregnancies? She has already. Would you like to tell about Ekika use of progesterone in IVF pregnancies?
Actually, in IVF pregnancy,
You are
we
using, I mean, IVF because there is a
yes,
hyperstimulated
this is
environment. Yeah.
see now. I mean, there is a big shift, Ruchika, when we say about the IVF pregnancy. If you are going for natural cycle, embryo transfer is different from HRT.
Frozen.
But as far as I say, when
Frozen.
it is HRT, it is started right from the beginning. Progesterone has to be given. Yes, at our center, we give it till 12 to 16 weeks, and then after that, it is being stopped. Because by that time, that uteroplacental shift does occur at 9 to 12 weeks. But to be on the safer side, till 16 week, it is fine. And then if everything has come up nicely, beautiful placenta, no spotting, no other signs or problem, then it can be stopped. But it's like it has to be given right from the beginning in ART cycles.
And
Basically.
like, is
Fresh
it
cycles, yes, and frozen embryo transfer depends the type of cycle you're falling to transfer in cases of
in IVF pregnancies, we have seen different types of progesterone being given together, like
Yeah.
Yeah.
hydrogesterone,
Yeah.
also micronized progesterone, and also along with aspirin.
Gestone
And gel
injections,
also. They give a gel also.
Yeah.
gel
Ekika, if you could
injections.
tell us about little on evidence for the luteal phase support post, the frozen embryo or a natural cycle for IVF. Because we see that patients are taking intramuscular injections, gel, oral, vaginal. I mean, they're really bombarded with the
yes.
progesterone.
Actually, they are being bombarded with 4 different routes. Most of the time I've seen they are being given favorably prolyton depot that may be for every 15 days and whenever till them. Then initially at the time of implantation for 8 weeks, they are given even crenon gel and then the oral digogestrone. I just have one patient. She got her IVF done in Sweden. Her embryos were frozen. She came to me when she was already 12 weeks from there. 16 weeks she landed here. I saw their protocol, what they follow. So what they have given minimum thing. They started her on HRT only, but there was only one route of administration of progesterone. That was 400 milligram BD they were
Yeah.
giving. And when she conceived and the cardiac activity came by 10 weeks to 12 weeks, they had decreased that also. And by 16, she was just taking iron, calcium supplement, just one multivitamin tablet, which they give according to what is their guidelines over there. So what, at least personally, I feel two routes like vaginal and oral progesterone is sufficient enough. If we are too very scared by giving only dydrogesterone, because we cannot see the blood levels of it. So most of the clinics do follow 10 milligram TDS dydrogesterone along with 400 milligram vaginal. That should be more than enough, and
And
there should
I
not be
think,
any
yeah,
add-on.
I do think, I mean, the evidence does tell us that, this can be quite dangerous, and the
Yes.
pediatrician can give us the kind of Priya used the right word, the kind of bombardment of progesterone from every route possible is given, uh, and that should also be stopped.
Yes.
And
Actually, we should
And
have to have a trust on this thing that only these two route or one route will be sufficient enough.
Yeah.
I
that's
mean,
the
that is
guidelines
what
say.
has to
According to
develop
the
in all of
guidelines,
us.
it is
Yes.
one is
A
sufficient
word,
enough.
Sufficient, they
a
say.
word about hydroxyprogesterone
can it increase the
ketroactic, which we all
myometrial
have been used.
contractility?
Dr.
17
Upa, you want to add
hydroxyprogesterone.
something?
Yeah, I was saying that there is lack of efficacy and safety concerns are there for 17 hydroxyprogesterone. Does it increase myometrial contractility?
Yes. Even the FDA has drawn
It
it
is
from the
withdrawn.
market,
Yeah.
and European Medical Emergency has withdrawn it in 2024 because it was a MEAS trial which found can reduce
It can increase
this
risk
thing,
of
hydroxy.
malignancy in the
There is no
offspring.
benefit in reducing preterm birth. I mean, there was no long-term side effects, but they withdrawn it completely from the market. They said that there is no increased risk of gestational diabetes or venous thromboembolism. There are no harm, but there is no benefit also in reducing preterm birth. So hydroxyprogesterone caprate used in our setup according to the results of the prolonged trial, because it has been
It is
withdrawn
a
from
true
the
synthetic
US
progesterone,
and
no? Because
European market.
it is a true
Yeah.
synthetic progesterone.
If you see the FOGSI practice points, they have said that you can give by two routes. Because dihydrogesterone has got certain advantages, that it has a higher affinity for the receptor. And I think it lasts, I mean, the action lasts for a longer time, whereas the micronized is absorbed better. So they found that in certain trials, they found that dihydrogesterone had lower abortion rates, miscarriage rates. So FOGSI practice points
And they also
says that you should
dihydro,
give.
yeah,
So that's surprising, because all these years I
FOGSI
used
has
to say that
totally recommended dihydrogesterone.
Dihydrogesterone and
Yes.
micronized progesterone.
Correct, brought about by Purnima madam. Yeah. And additionally, dihydrogesterone has immunomodulatory property also and less sedative property
correct.
also.
So that combination is said to be beneficial. So we can't, I mean, of course, don't give it in very high dose.
Even
but
FIGO guidelines have also recommended. Yes, madam.
So I think not
FIGO
more than
guidelines
2.
2023 have also recommended.
Yeah. Not more than 2. I don't think we
Yes.
should have HCG injections also and Proluton depot also.
Yeah.
But
Yeah.
these two are, there is some rationale in giving them.
Yes, according to the ESHRI guidelines also, in intramuscular HCG has no role in recurrent miscarriages. It not be prescribed. So PRISM trial also did not found any in spontaneous miscarriages benefit of progesterone. PRISM is also. Now coming to RCOG guidelines recommend 400 microgram BD of progesterone till 16 weeks of pregnancy. So now Ekika will answer about this IVF progesterone, about use in luteal phase defects. So this we have already
I think
discussed.
she
in
has
previous
covered
slides.
most of it.
Yeah.
So I'll just run through this slides where LPD, we know in assisted reproduction there is majorly there, and there is so it's an iatrogenically induced luteal phase defect because of the gonadotropin stimulation, and because of this we need to give progesterone, especially in the frozen cycles. Ruchika, go to the next slide.
Yeah.
Yeah, so progesterone supplement, no, please go to the previous slide, please. So you need to start it, yeah, either one day after ovulatory HCG dose or on the oocyte retrieval or on the day of embryo transfer. Ekika, at what phase do you normally start the progesterone?
Actually, the thing is that if you are doing it in a fresh transfer, the day you do the pickup, that is the time you start the progesterone. And
Yeah,
if
so
you're
that's
doing
an
a frozen
important
embryo
point.
transfer, then entirely, since the things have shifted, you do a natural cycle transfer, you do a HRT cycle transfer. So accordingly, we will be starting the progesterone in those cases.
Okay,
But the
so
key
I think
message,
it's a
Dr.
very
Priya,
important
is
point.
yes, yeah. The key message is because if you're doing a fresh transfer and we have used gonadotropins, then there will be chances of luteal phase defect. Specifically, sometimes people do give SCG and DECA trigger both. And then also they do a fresh transfer because by giving progesterone, they can save that that cycle also.
So even the evidence which we found did show that the gold standard was vaginal progesterone. Even this Delphi consensus did show that the vaginal route was one of the best. And this was a paper where, it was different RCTs were
Gel preparation.
evaluated. And here they found with the vaginal progesterone, 37% higher live birth rates also were there. And even in this study group where PCOS patients, they underwent IUI and they were given the vaginal progesterone 600 milligram for the luteal support, and they found that the miscarriage rates were far lower in the where progesterone was given, and the pregnancy rates were higher. Now, even in the FET cycles, yeah, there was a paper which even compared the 900 milligram group versus the 1200 group milligram per day, and there was evidence that when 400 milligram 3 times a day was given, there were the higher clinical pregnancy rates were far more. And most of the evidence does show that the dual progesterone approach is the best, where vaginal progesterone as well as subcutaneously, which I think Ekika has already covered that, and combine vaginal and subcutaneous progesterone here. So 25 milligram per day with vaginal progesterone 800 milligram per day before FET was given. And it was found that the implantation rates were far better and the miscarriage was far lower. And it had higher progesterone levels 1 to 2 days before the FET. It was seen that higher progesterone more than 21.9 nanogram per ml was achieved. Go to the next slide, Ruchika.
One thing I also want to add, Dr. Priya, in this, here we have given two progesterone, a vaginal and a subcutaneous. Initial for the first 5 days before the embryo transfer, giving an IM progesterone also really gives a good progesterone value of more than 20. So something between 20 to 35 is the one which is a very good progesterone and very good for the implantation. Once you have transferred, then you can, change the route of progesterone. That is what in most of the cycles we do here. The only problem sometimes which we find with that, some patients do have spotting because you have given a good amount of progesterone for a longer time. So there is a good serum
Which is the
progesterone.
progesterone molecule?
IM progesterone.
IM?
This is the good old IM progesterone.
Natural.
I'm saying. So it's only for 6 days. I agree it is painful, but for
It
6
was
days giving
sustained.
it a good
Progesterone and
yes, good progesterone values. And once you transfer, you can shift it again to the vaginal and oral route. The only thing which we have seen, some patients do complain of spotting because there is a sudden shift of the serum value of progesterone. So during implantation, but then you can continue on it and it really goes out well. So IM progesterone for 6 days, I don't remember, but there are studies, old studies, which really say IM is also good for that. During that period, don't give any other progesterone, but then transferring it and then following your oral and vaginal.
Yeah. Even studies have found with the use of dihydrogesterone, hypospadias, ambiguous genitalia, and congenital cardiac defects in the fetus. It was a WHO pharmacovigilance database, VG base, but it had flaws. This was with dihydrogesterone because these databases relied on voluntary report.
Is Neelu still there?
And there were certain confounding factors like advanced maternal age or other consideration. Yeah, Dr. Neelu has already told about the autism and attention deficit hyperactive disorders.
Yeah, Dr.
And
Neelu, if you
as
want to
Dr.
add
Geeta
something
Balasarkar
here,
madam also told it, progesterones.
Ruchika, I think Dr. Neelu is
She had
there.
already added the same thing.
You
Yeah,
want to
I
add
think it's the
something more?
same. It's the same. They're all same thing: autism, ADHD,
Yeah, she
epilepsy, neurodevelopmental disorders, intellectual disability,
Yes.
epilepsy. All these has been associated.
Masculinization of female fetus. Have you ever come across? Neelu may not have, but her
No,
husband is a
no, huh.
flourishing pediatrician, so he might be telling her, in the evenings that I saw That's why I'm asking
Yeah,
her.
They don't talk
yeah,
medicine when they come home.
Yeah, actually,
yeah.
ma'am, natural micronized progesterone is safer. And so even in MHT, also to prevent endometrial hyperplasia from
So one
unopposed
thing,
estrogen.
sorry, Dr. Ruchika,
Yeah.
we haven't
Yeah,
discussed about the
Sudeshna.
maternal side effects.
Yeah.
In pregnancy, I have seen patient with severe pancreatitis leading to like prolonged hospitalizations. And both I and Shilpa has seen a patient with extreme high bile acids
Yeah.
because of
Yeah,
Our
so
next
there's
slide is in
one scenario.
this only.
Yeah, Ruchika, we are going to come here
Achha.
to that.
I thought
So
you
this
have
is
gone.
the
I think Ruchika, there's some problem with her speech.
Okay, I'll take over.
Yeah.
hepatic stress,
Ruchika,
particularly
are
if
you
there
here?
is pruritus or LFT abnormalities. Yeah. Yeah, I am there.
Just switch off
Progesterone
your video.
metabolites
It'll
can
help.
affect
Switch off
Because
your
your voice is
my.
breaking in between.
The speed is low.
Okay. Let me switch off my.
You're not able to?
So in intrahepatic cholestasis of pregnancy, can you hear me?
Yes.
Yes.
Yes. Even progesterone have been linked with increased thromboembolism risk. And we have been using progesterone for delaying menstrual cycles. So for these, even medroxyprogesterone, acetate, and these have the highest risk thromboembolism. PCOS patients also sometimes, instead of dealing with the metabolic part of PCOS, patients doctors just blindly prescribe progesterone.
Every month.
So what is your experience of prescribing? Patients are traveling and they are going to Vaishno Devi for some tourism and they are saying that I want to delay the menses. This is an abuse of progesterone. So recently in Economic Times also there was a buzz that after using progesterone for delaying menstruation, there was an incidence of deep vein thrombosis in a female. So this regestrone we just give, norepinephrine, and that has also been linked with this thing, with thromboembolism.
Whatever
Dr.
said
Ruchika, I
and
think
done.
here again we come to the counseling part of it
Yes.
because high altitudes, long hours of flight travel, all these add on to the
Yes.
chances of deep vein thrombosis in these patients. So they need to be counseled that they need to be well hydrated, they need to keep moving in the flight, and continuous calf muscle movement. So basically counseling and how much you tell the patient that this may be a side effect and you need to be careful that that needs to go on with the prescription.
Yeah.
And one more
I
thing,
think that can
Ruchika, I
prevent
want to say out of those
And no
progesterone,
prescription on phone. Yeah.
out of all the progesterone, norethisterone has the least DVT profile.
Yes.
It's the
Yes.
newer ones which
Yes.
have. So in the
Yes.
case where absolutely rightly said by
Yes.
Shreya, probably it might not be the progesterone, the culprit, the high altitude, the the walking and the prolonged staying, and maybe the status, whether obesity, there are a lot of other factors which come in. If I have to give progesterone, and for a long time,
Yes.
out of everything, norethistron has the least DVT chances than the newer ones. It is the other way around for estrogen and progesterone. So
Desogestrel is associated with increased risk.
yes, yeah.
Also,
one common situation which we encounter is when we give progesterone for postponement of menses, and if they conceive, then the patients are very much worried whether they should continue, what side effects would be on the
They should.
pregnancy.
They should continue.
Yeah, but
So it
again, your
depends on
counseling
which
plays a
progesterone
role.
was taken.
Sorry,
Yeah, but
maybe.
again, your counseling plays a
and
role. You tell them progesterone is what is there during pregnancy, and if you counsel
Yeah.
them well, then it's
Yeah.
very acceptable.
Right.
The
And which
problem
So,
what we
progesterone?
have
Do
is
you
with
give or do you
norethistron, I
not
think
give?
because it has
experience of
androgenic side
Yeah, but Dr.
I
effects,
think
is
Sudeshna, I want
when
to
if the
ask, giving
patient gets
two, three
surgery,
people.
norethistron
you
for
have an
5
issue.
days.
Sorry,
We
sorry.
give it for 5 days for like, okay, if we are giving it 5 days or 10 days for postponement, norethistron. I'm just asking clinically because I have not seen any studies. And this she conceives. So will 10 days of progesterone, norethistron will be that detrimental? And initially, if you
No,
see
No,
in
no.
the
No,
initial
not
phase,
at all.
yes, till the
No.
15
not at
days,
all.
the blastocyst implants and then start growing. For first 15 days, it is actually resistance to most of the thing. That is the core time when it is resistance to everything. So there is
No,
I
they
mean,
do not.
he can be
They
told to continue if she
absolutely
really wants
should
to
be
keep it.
and should
It's a
be
patient.
continued.
I
Yeah,
think
See,
because
proper
first
counseling
15
here is
days of,
important.
yeah,
You need to
first
counsel.
15 days
yeah,
or the immediately post ovulation, first 15 days is do or die. Either the pregnancy survives or you have a miscarriage. I don't think any medicine in the first 15 days that you conceive really affect a pregnancy. It is only after the 15 days that we
yes,
say that the medicines affect the
that
pregnancy.
starts affecting.
Yeah.
yeah. Do you have experience of prescribing progesterone? I mean, we prescribe progesterone for AUB, and we haven't done endometrial biopsy because in a perimenopausal women we think that it's just anovulatory bleeding, and later such cases can be diagnosed with endometrial carcinoma. So can any of the panelists would give a message to the audience regarding this?
So somebody who has other risk factors for irregular bleeding,
Yes. Yeah,
if
Ikita.
she has obesity, if she has diabetes, hypertension, definitely I would not give her regesterone or any kind of progesterone
Without checking.
to manage that without a biopsy, especially after 40. Now, before 40, sometimes we generally give them because they have PCOS or some kind of uh, unstable endometrium. To stabilize, we do give younger women, like definitely less than 40.
And we also need
I
to
wanted
Here
to
also
add one
counseling
thing.
is very
we also
Dr.
need to look at
Dr. Uma
the
wants to add something, please.
we also would like to know the transvaginal findings. How is
Yes, yes.
how is the vascularity? Because in
Right.
endometrial carcinoma,
Yeah.
if we put on the Doppler, the vascularity
Right,
is
yes.
abnormal and very high
Yes.
and suspicious.
Yes.
So in such
So an
patients,
ultrasound and a
we should
biopsy.
do a biopsy before starting.
Yeah.
So the take-home message is we have to evaluate the patient first before putting the patient on progesterone. Very simple and straight. You can
And
weigh
I want to
Evaluate
other
means the
agents
question
recommended
here
in
is, sorry, Ekika is wanting.
yeah, Dr.
Yeah.
Sudesha, I just want to add this thing. Anyone after 40 or 42 irregular bleeding, first and foremost, biopsy is the
Biopsy.
must, as what madam is saying.
Yes.
Yeah.
After biopsy,
Ultrasound
if it
and
is a
biopsy.
hyperplasia without atypia, then unfortunately progesterone is the treatment of choice. If it is endometrial hyperplasia without atypia,
Which
either we
is
give
most of the
progesterone for
times
6
you
months. Yeah.
find.
Yeah.
May
6
I
months.
add
Or
Then
we
here?
give
you miss,
Farina.
May I
even
add
if you,
here?
Yeah.
Thank you very much. The thing is that sometimes we do give progesterone in borderline thick endometrium, but the trick is to evaluate her
Yes.
post-menstrually whether she has shedded it properly. If she
Yes,
has shedded
that's
it, you are safe. But definitely take care of her abdominal girth and her BMI, because we have more visceral fat, because progesterone sometimes are safe but females are not.
Yeah. So I think that important
Yeah, because you
point
give
number
one
40,
one
we
time
need
you
to,
give progesterone, they continue.
yeah, lifelong.
And
And they don't
even
even
on
follow
day two
up.
of the cycle, still you have very
Self-medication.
if on the
So,
day two of the cycle it's not being shed, that is called medical curettage, which madam is talking about. You give progesterone, it starts shedding, and if it is still it high holds even after 2 cycles, then we really have to retrospect and think, are we missing something? Because endometrial carcinomas are because of estrogen. So is it like giving progesterone is useful, or we should do a re-biopsy, or we should do a hysteroscopy? That is what we have to think, because at 42 also you get patients who are so much prone to having endometrial carcinomas.
Yes.
Yeah. So that's what I'm saying with doing hysteroscopies. If you do about 100 hysteroscopies, you might pick up those two endometrial carcinomas or complex hyperplasia with atypia. But for that, I think it is worth doing those 100 hysteroscopies just to pick up uh,
Okay.
those two.
So
So
I
we
think
have to use rationally progesterone, correct indication, correct dose, correct duration, proper evaluation before starting, and regular follow-up as brought about by all our panelists. Progesterone is beneficial when used appropriately. Avoid overdose, avoid empirical therapy. Diagnosis should precede treatment, and evidence-based practice is essential. With this, we finish our panel, and it was very fruitful discussion with all the esteemed panelists, Dr. Sudeshna, Ekika, Dr. Neelu, Dr. Navneet Desai, Dr. Nidhi Shah, and Shreya, and Dr. Uma Savan.
So I think all our panelists have performed
Thank you
wonderfully.
very much.
I
So,
would like
Thank
to
you.
thank my
Thank you very much.
co-moderator
yeah, we
Ruchika Garg.
invite Purnima,
I, I would like to thank Dr. Purnima Satoskar,
Madam.
Dr. Milind Shah sir, for giving us this wonderful opportunity. Thank you
Thank
very
you,
much.
everyone.
Thank you, Dr.
Thank
Ruchika
you.
and Dr. Priya, for taking the panel
Thank
so
you,
nicely,
ma'am. Thank
moderating
you
it
so
very well.
Thank
much.
you.
Thank you very
Thank
much.
you to the audience also. There are like very useful inputs from
Thank
the audience and the other attendants attenders also,
Yes,
other faculty like Madhuri and I think
even
Shilpa
Satoskar
has.
madam. Yeah,
Yes, Ma
even
yes, yes.
Let me
Satoskar
thank
madam.
everybody formally. I would like to thank Dr. Milind
Dr.
Shah for
Milind,
the idea of the having a series of webinars. Then our chief guest, Dr. Ashok Khurana, who has a very busy schedule, for making himself available and encouraging us. And our guests of honor, Dr. Amey Purandare and Dr. Saurabh Dani, for being here. And of course, our chairpersons and the panelists and the moderators and my co-conveners, Ruchika and Priya. And finally, Divya for arranging the whole thing, and Corona Remedies for sponsoring this series of webinars. And we look forward to discussing all the drugs in detail like we did today. Thank you very much, everyone.
And
Thank you.
special,
Thank you
special
very
thanks to
much.
Purnima for taking all the efforts. It was really a really wonderful webinar. Even the panel was superb. Thank you everyone, all the panelists, and very well conducted Priya and Ruchika. Huh? Good, it was a wonderful
Thank
thank
you,
webinar.
you.
sir.
Thank you very much.
Thank you, Dr.
Thank you,
Milind.
sir.
Thank you,
Thank you.
Dr.
I think
Purnima.
Thank
Priya
you,
Thank you,
and
madam.
Sudeshna
Ruchika,
ma'am.
can you make one red flag warning? When we prescribe this, you can just make a list of things for the patients and you can maybe put it on our group and we can start following that.
Yes,
Yeah,
yes.
evidence-based.
Yes,
Yeah,
evidence-based or
Evidence
whatever, side
based.
effects. For the patient, it is just side effects, na? Red
yeah.
flags, what they have to watch out for, report to the hospital immediately.
Okay, ma'am.
Yeah,
Thank you
we'll
very much.
share it soon.
Thank
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 you,
you.
you.
ma'am,
Thank you
for the
very much. Thank you,
opportunity.
Milind sir.
Good
Thank
night.
Thank you,
you.
Milind
Thank
sir.
you very
Thank
much.
you, Dr. Purnima,
Good
Priya.
night.
Thank you.
Thank
Thank
you.
you.
Thank you, madam.
Thank you.
Thank you, Dr. Milind. Thank you.
Good. Wonderful.